Good morning, everybody. We're going to go ahead and call our meeting to order. And it's been kind of an interesting, busy morning. I don't know how many of y'all have ever gotten up in the morning and gone to work and didn't bring your telephone with you, and then found out when you got here you didn't have it and you were trying to find it, but you couldn't remember anybody's telephone number to call them and get your phone for you. That's what I've been doing this morning, but we came through, so we're there. So put up with us if we're a little bit out of order, but we're glad to have you all this morning. Appreciate your interest in being here with us. We have a sign-up sheet if we have time when we finish our presenters and our agenda. If anybody wants to make a public comment, we would give you that opportunity to do that for a couple of minutes. And where's the sheet? Have you on the back table back there? So do that and do it. But we're going to have some presentations this morning, and a couple of these are going to be online, and we're going to go ahead and get started with that right now. And first of all, Dr. Bill Cleverly, he presented to us earlier some information, but we thought it was better if he was able to talk with us again today and get into a little more depth and detail of that. So that's what we're going to have first. And are we ready to go? Okay. Dr. Cleverly, you there?
Yes, I'm here. I can hear you. Can you hear me?
Yes, we can.
Okay. Well, I am, I'm going to share my screen in just a second, but I wanted to make kind of like three kind of like understanding before I start. It's my understanding that, you have very limited time, and I understand and respect that. And so I have been told that at 10:30, I better be done. So I will definitely promise you I will conclude by 10:30 if that's still the objective. I'm secondly making an assumption that you either have or will have shortly copies of the presentation that I'm going to be using. And then kind of third and finally, if you have questions as I go through anything today, I would urge you to basically stop me and basically I'll try and answer a question then. So I'm going to start by sharing my screen, and you should be seeing it now. Are you seeing my screen?
Yes, sir, we are.
Okay. I'm going to start then on this, and actually I'm going to do one other thing on this. So these are the three questions, at least, that I was asked to address on behalf of the Georgia Alliance some time ago. And question number one was, are there differences in operating performance between CON and non-CON states? Secondly, how did Georgia hospitals compare to both CON and non-CON states? And then third, as we got into the study and looked at it more in depth, we found out that the presence or absence of Medicaid expansion had a significant impact on the results of some of the metrics that we were using. These are the major arguments that are used basically to retain CON, at least that I've run across. One is cost control. Two is quality assurance. Three is access to care. And four is public interest. And I would be remiss if I didn't point out that for each of these four arguments, there are counter arguments for each of them that CON is not necessary. The only other thing that I would say on this is that there was recently a study that was done in 2020, and they looked at 90 research articles on the effectiveness of CON. And after the review of all this literature, they came to the general conclusion that there was no general conclusion, that some of the studies found CON effective, some of the studies found that CON was not effective. So, what we will be presenting today is just another set of data that you can do with as you like. So with that, here are the data sources that we used. First of all, we used Medicare cost reports from 2017 to 2021. These provided us with financial statements for virtually every hospital in the US. The reason that we used a 5-year study period was to recognize that there could be some abnormalities in the data that occurred during that time period, especially as a result of the COVID years. So we attempted to use 5 years of data for all the data sets that we pulled in. Secondly, we used MedPAR data, which is really all hospital Medicare inpatient claims, again, from the year 2017 to 2021. The HOPS data set, again, 5 years of data, is all Medicare outpatient claims for all hospitals in the US. And then the last final data set that we pulled in was the Part B carrier files, which, again, 5 years of data, and they provide all Medicare Part B claims submitted on a CMS 500. We use that basically to derive data for one of the metrics that we use, which had to do with ambulatory surgery centers. Here's the breakdown for the states, where it was 35 states that are designated as CON states, at least at the time we were looking at this data. Of those, 80% or 28 have Medicaid expansion. 7 have not adopted Medicaid expansion. There are 15 states that do not have CON. 11 of those have Medicaid expansion. 4 do not. And then this is just a little kind of like table to represent it. So here's CON. Yes, CON, 28 states with Medicaid expansion, 7 with CON without Medicaid expansion. Georgia is in that group right there of the 7 that have CON without Medicaid expansion. The other states that are included in that, because I'm going to be making some comparisons with that group, are Florida, South Carolina, Alabama, Mississippi, Tennessee, and North Carolina. So you can see that by and large, they're almost exclusively southern states. Here's just a map. And again, I'm hoping that you will all have an opportunity to at least have access to the presentation if you don't have it now. So this is a map of the CON states. You can see those in green represent states that have CON.
Dr. Cleveland,
yes, sir.
Let me interrupt you for just a moment. We have a question for you, Dr. Newton.
2 things, sir. One, I did notice you used a lot of Medicare data. Was the goal of that to make sure that we were not using charges, which are vastly different than cost? Is that like Medicare is allowable when you're trying to compare costs in different facilities?
No, that's a good question, but that's not the reason, because we are showing charge data.
Charge data.
Yes, we're showing charge data, and then we're also developing a measure of overall payment.
We were told by a hospital administrator, a recent meeting, that charge data could be 3 to 8 times Medicare's allowable. Is that a ballpark of accurate?
It's probably somewhere in that range, depending on the hospital. 3 is on the low end, 8 is on probably the high end. Again, charges are basically sticker price. It's not necessarily what an individual patient will pay, but there are a number of patients who have copays and deductibles where that charge portion could come into play. And so charges were used as one measure, not the only measure.
Gotcha.
But it is one of the measures that we'll look at, which is, we'll refer to it as a sticker price.
But if you don't mind going forward, I guess eventually we'll have, with the hospital transparency data federally required now, we'll eventually know what a little something closer to the actual amount hospitals get as opposed to the charge. Finally, I guess I was curious about the fact that Georgia expanded Medicaid in 2019, and it did get delayed for 2 years implementation. So not obviously people are not on it, but we did expand Medicaid. And there's really, in Georgia, anyone who's either working or volunteering or in training part-time from 0 to 400 plus is eligible for health insurance, either under 100% through the citizens who pay, who support the Georgia pathways. And if you're over 100%, you get commercial. I guess I'm looking at your data. It's from 2021 and earlier. So you don't have it updated. Obviously, after the 2-year delay by the current administration, we didn't implement our Medicaid expansion until July of this year. And so we obviously don't have a lot of people signed up for it right this minute as we would have if it had been 2 years ago. So is it we're looking at this and calling Georgia a non-Medicaid expansion state because of where we were in 2021?
That's correct.
Okay. All right.
You know, and again, you know, you will see that Medicaid expansion makes a huge difference in some of the metrics.
Yeah. Thank you, Dr. Clever. Go ahead, please.
Okay, so this is the map then with the color code for Medicaid expansion. And again, it's showing Georgia in that point in time as a non-Medicaid expansion state. 2022 data was not incorporated because at the point in time when we started and completed the study, we did not have access to all the 2022 data. So here are the areas of performance that are reviewed. One is pricing of services. And to the point that was made earlier, we're looking both at what we'll call sticker price as well as net price that's actually paid. Secondly, we looked at costs that are incurred by the hospitals because ultimately, if a hospital is going to stay in business, it's going to have to cover the cost that it incurs in providing service. And we wanted to see whether or not CON status or Medicaid expansion had any impact on it. And then third and finally, the issue of profits. There's been a lot of discussion about CON both ways. Some argue that the presence of CON enhances monopoly power and raises profitability for providers. Others will argue the reverse, that it restricts competition and therefore basically enhances that. So here's the price metrics that we use, and I'm using the term price. We use the hospital charge index. There's an appendix that shows how that's defined, but that is sticker price, and it is a metric that measures overall all hospital patients, case mix adjusted for differences in procedures, and it also adjusts for cost of living. We also looked at the average emergency room rate, which was then wage index adjusted. And again, the ER rate was used to your point that you made earlier. There are a number of patients that walk into an ER that wind up being responsible for the charges of it. So that rate is very important. Average outpatient colonoscopy rate, you'll notice here, this is in ambulatory surgical centers. So this is not hospitals now, it's ASCs. And then last and finally, net patient revenue per equivalent discharge. This is also wage index adjusted. So this represents the actual amount of payment that was received per equivalent unit of service on a cost of living adjusted basis. And we'll start in with some of the data then. So here's the overall charge index. These first two bars represent Georgia, and then states that are like Georgia that have CON, but at that point in time did not have Medicaid expansion. The set of green bars basically represent states with Medicaid expansion. And then we looked at the differentiation between those states with CON and those states without CON. And so what you'll see from this is that in terms of at least sticker prices, equivalent states that have Medicaid expansion, those states that also had CON had significantly lower prices. This is all CON states and non-CON states, regardless of Medicaid expansion. And you can see again that the charge structure is lower in those states with CON. And then this is the Medicaid expansion, not differentiating or blocking for CON status. And you see there's an impact associated with this too. States with Medicaid expansion appear to have lower overall charges. Average net patient revenue per equivalent discharge. This metric now is taking a look at the actual payment, not the sticker price that was received per equivalent unit of service. And you'll see that Georgia, again, is higher than its peer group. In terms of states with Medicaid expansion, when we look at the differentiation between CON and non-CON status, you'll see a marked difference, that those states with CON and Medicaid expansion appear to have significantly lower average net payment than those without CON. This is the CON status. And again, this is not differentiating from Medicaid. You'll see again, general conclusion, CON states have lower overall payments. And then finally, Medicaid expansion and no Medicaid expansion, not differentiating for CON status. And again, you'll see the fact that Medicaid expansion and CON status appear to be positively associated with lower levels of payment. Emergency room charges adjusted for APC weight and wage index. And I need to explain just a little bit this APC weight. There are 5 levels of ER care that are coded. Each of those has a different weight that represents the underlying cost, and it's basically figured into the Medicare payment rates. So this is the average payment per APC weight 1. And again, you see Georgia and its equivalent or comparable states. Then you'll see the impact of CON status, basically, and Medicaid expansion. And you can see again, CON status appears to have a favorable influence on the charge structure for ER rates. When we just look at all CON states without blocking for Medicaid, we see again, same trend, lower rates. And when I look at Medicaid expansion, again, I see lower overall rates or charges for ER rates with those states that have Medicaid expansion. And then finally, we looked at outpatient colonoscopy charges in ASCs. Again, these are not hospitals. These are freestanding surgery centers. And this is 2021 data now. And we looked at the rate, again, per APC weight 1. And we'll see Georgia has really low rates in this area. There's very little difference between CON, non-CON states that all have Medicaid expansion. CON states not blocking for Medicaid expansion appear to have slightly lower payments. And then the Medicaid expansion appears to have really little, no impact on rates. So this is the one area where we found basically Medicaid expansion appeared not to have any influence on pricing. On the provider cost side, again, recognize, just to put this in perspective, that hospitals with higher cost by necessity are going to have higher levels of payment to stay in business. So here's the cost structure. And again, as I look across at the data on this, the kind of general conclusion is that CON status and Medicaid expansion status appears not to have much of an influence on overall cost structure. Average length of stay, again, there was very little here. We saw that Georgia has an unusually high length of stay for that 5-year time period. I think some of that might have been due at that point in time. You're going to see to levels of charity care provided. And then lastly, this statistic on cost structure. You'll see that the state of Georgia, for that 5-year average, had 5% of their total charges associated with care delivered to charity care patients. Just to put this in perspective, Georgia was the 3rd highest state in the US in terms of charity care. Other states without Medicaid expansion, CON, you can see a little bit lower level of charity care, but still high compared to all of the others. And again, you'll see the key bar comparison here. Medicaid expansion appeared to have a significant effect on the levels of charity care provided. And again, it would be interesting to take a look at 2022 data now and see whether Georgia's numbers drop as a result of its, kind of like more complete introduction now of Medicaid expansion. Last and finally is the issue of profitability. And so looking at it here, Georgia and states with CON but without Medicaid expansion very similar in terms of their operating margins. If I look at those states with Medicaid expansion and compare states with and without CON, I can see that CON states had significantly lower levels of operating margin. When I look at all CON and all non-CON states not blocking for Medicaid expansion, I see again that the rates are significantly, levels of profitability are significantly lower in CON states. And with Medicaid expansion not blocking for CON status, I see that Medicaid expansion appears to have a small positive influence on basically the level of operating margin. Kind of going through that and kind of looking at my watch, basically the kind of conclusions that we reached from the day that we went through is that charges are lower in states that have both CON status and also have adopted Medicaid expansion. Said here, however, Medicaid expansion appears to be the more important factor in the pricing of the hospital services. Actual payment of hospital services is lower in states that have both CON and Medicaid expansion. CON states are also providing more charity care in their communities than non-CON states. However, Medicaid expansion status appears to have a greater influence. As I said earlier, Georgia has the third highest level of charity care in the US. And this, at that point in time, was most likely affected by the state's non-adoption of Medicaid expansion. Finally, on here, cost structures do not appear to be materially affected different in either CON or non-CON states, and adoption of Medicaid expansion may have a somewhat greater influence on cost. Georgia's cost structure is above the US average, but it is similar to those states that had not adopted Medicaid expansion. And then kind of down here, the last thing on here, operating profitability appears to be higher in states that do not have CON regulation, regardless of their adoption of Medicaid expansion. So in general, that is it. I've got about 10:28. Do I have any questions?
Dr. Clever, thank you. You did a good job explaining in a short amount of time, and you do have a few questions. Leader Beverly has a question for you.
Yes, sir.
Thank you, Mr. Chairman. I have 3 questions for you. The first one is, when you did the APC weight, is it based on CPT codes that you looked at across the board, and what the billing was for each CPT code? Is that how you came up with the APC weight?
Yes. Medicare has assigned a APC weight by CPT code. To use the simple example, when we did that ER adoption and we used the APC weight of 1 to kind of standardize it, I can't give you the exact numbers, but a level 1 ER code, I believe, has an APC weight less than 1. A level 5 CPT code 99285 has a APC weight that I think is above 5. So when we did that, yes, we take the overall mix and adjust for it on it. Does that answer your question?
Yeah, it does. Thank you. I have 2 other questions.
Okay.
The second one is just my understanding. Why use colonoscopy as an outpatient charge? Why'd you use colonoscopy and not some other procedure?
That's a really good question. I did it because if you look back, we focused then on outpatient surgery centers, freestanding surgery centers, not hospital-based. One of the primary areas of surgery for ASCs is GI procedures. So that's why I selected that one.
Thank you. And then finally, last question I have is on the charity care from 2017 to 2021. That 3.27, which is 2.5, 3 times as much as what the Medicaid expansion is. How much does that actually represent in true charity care cost? Like the net cost of charity care in the state of Georgia at that 3.27 above the sort of national average of 1.23. What is that true cost? If you could help me with that.
I can try. When you say true cost, I assume you're talking about the underlying provider's cost?
Yes.
So a rough rule of thumb on that, and again, it is a very rough rule of thumb. is that if my charges are $100, my cost potentially, depending on the facility and its circumstance, could be $20 to $30.
Yeah. Thank you.
Uh-huh.
Thank you, Mr. Chairman. And thank you for your report. I know you did mention early on who asked you to do, did you say the Georgia Alliance asked for this?
Georgia Alliance asked me to start conducting the study in, golly, I don't know when it was, June or so of this year. We started to assemble the data.
Yeah, and it's a lot of data, and I appreciate you looking at those multiple years. I guess I'm a little puzzled on whether, if when I look at the net patient revenue or the emergency room, I guess revenue or charges, whichever you want to call it, is higher worse for a consumer and better for a hospital, or example in profitability, is higher profitability better for hospitals in Georgia or lower profitability? I'm just, and then again, and then you got to pull in the insurance company in between the patient and the provider, which is setting premiums with an MLR and all. So I'm just curious, are we trying to make a conclusion, say an operating margin is higher is better, higher or lower is better, and on cost is higher better or lower better?
Depends on which side of the table you sit.
All right.
I mean, if in terms of operating margin, obviously hospitals would prefer to have a higher operating margin. In my earlier life, when I was more involved in research, particularly on the finance side, I used to say that basically to remain viable in the long term, a hospital at least required an operating margin of 4+%. And the reason for that was, which you can see, the tremendous expansion in technology and development and replacement of equipment and facilities with structures and equipment that are multiples in terms of cost of what they were originally in terms of cost for their quote replacement items. So the reason the margin was used is that a lot of people have argued that CON promotes basically or retards competition, and as a result, you're going to see quote monopoly profits occurring. And at least from the data that I've looked at, that definitely was not true. That if anything, the reverse was true, and that those states without CON appeared to have higher levels of operating profitability. I'm not certain I answered your question. On the cost side, again, it depends on which table you sit. In terms of charges, I can tell you with almost absolute certainty, no hospital wants to have high charges, okay? They all want to have charges that are lower for a variety of reasons, but they don't want high charges. But the charge structure is developed based on what they need to make up for the discrepancies in payment by Medicare and Medicaid, because they do not pay full cost for the services they provide, to cover charity care, and also in some cases to make up for the differences between what some commercial payers are paying in relationship to the underlying cost. So there's a small segment, depending on your payer mix, of patients that do pay on the basis of charges. And the balancing equation, unfortunately, is that lever. So, again, hospitals don't want charges any higher than they need to be, but they also have to set them at levels where they can basically maintain their financial viability.
Well, thank you. Thank you. I know that the operating margin for hospitals can be ones that are incredibly strong margins in Georgia, maybe records. And then there's others who are worried about making payroll, 2 Fridays from now. And so we seem to have a huge range. And I guess that doesn't get captured in state by state data. I mean, unless you had, reference bars on all the data, which would be a cumbersome thing. But I don't guess Georgia's are any different in our range of profitability than anyone else, or did you not? You wouldn't have looked at that.
The answer is, when we pulled down the data, we pulled down those levels of operating profitability for every hospital in the U.S. So, then we took that data and combined it to create an average. So, no, I mean, I looked at it, but if you're asking me, can I tell you at this point in time what the distribution was? No, I cannot.
Thank you, Mr. Chairman. Thank you for the presentation. When you were, calculating the cost factor, did you compare and put in the advantages that the hospitals have for not having to pay taxes compared, which is a huge amount of money, and not having to pay taxes not only on their land but their profits or whatever, compared to freestanding surgical centers and not-for-profits?
In answer to your question, I think I'm going to, if I don't answer it correctly, you tell me. We use the cost measure that's in those Medicare cost reports. They do report operating cost. And if it was an investor-owned facility, I'm assuming that their property taxes and other factors would be included in it. For nonprofits, it's not included in them because they're not paying taxes. So the margins that we showed did not differentiate between, if you think of it in this way, investor-owned and non-investor-owned hospitals. But it does include their total cost on it. In the investor-owned side, it should include all of their taxes.
Okay. And the other question is, on most of these bar graphs, you started out and one time you said significant differences. But if you look at these graphs, you go back, they're not significant differences to me. And you went back to just saying, advantage and not saying significant.
Again, significance, I'm a statistician. I'm not saying that there is statistically significant differences in these. Some of them are just so large and so consistent in direction that if I use the word significant and in other cases didn't, there were certain slides where I thought that the evidence was pretty clear cut on it. And I think you can see that for yourself when you look at like operating margin. That is so clear cut that I don't think there's any other conclusion than what CON status appears to have a retarding effect on the level of profitability.
Thank you.
You're welcome.
Chairman.
Thank you. Thank you. I would just like to continue down the questions with Representative Mark Newton talked about was, can you talk about the stakeholders, the other two stakeholders, insurers and patients, and how this data, how we should look at it from a layman's term of how the consumer would be impacted and the insurer would be impacted. And you can just use a couple of your examples, like operating margin or charge index, or either way, it doesn't matter. I just want to see what the lens is that you all took from this, from the consumer and the insurer.
Sure. In terms of at least the charge index metric, as I looked at that metric, and again, I don't know if I'm still sharing my screen or not, but if I looked at the hospital charge index metric, and I'm trying to block out for the impact of Medicaid expansion because it did have an influence. And I look at that index being 89 for CON states with Medicaid expansion and 103 for non-CON states with Medicaid expansion. That is a sizable difference. That is significant. And to the extent that there are patients who do pay on the basis of charges, and there are insurance companies that pay on the basis of charges. Are they the majority of payers? No, but they can be a significant force. And a lot of discussion on some of the price transparency that originally developed focused on what we referred to earlier as sticker prices. And those were the initial rates that were published because you had people that walked into an ER, for example, or were admitted and wound up with a hospital bill that was really high because they had no underlying insurance coverage. So that's the charge side of it. When I looked at emergency room charges, for example, and again, that's a key one that often surfaces for patients that walk into an ER, because if you walk into an ER, sometimes it's, it's not scheduled or anything else. You're in that emergency room because you got a problem and you want it fixed. There's a fairly significant difference there, I think, between states with CON and states without CON, which would be a benefit basically to patients and insurance companies for that matter. The last area I think you talked about was the level of operating profitability or margins. To the extent that you've got a firm, that hospital in this case, that's making higher levels of profitability, that profitability ultimately is coming from its customers or patients. So, from an individual patient's perspective, probably what you'd like to see is a margin of 0 or maybe even negative. But, hospitals could not operate and provide service at that level. So again, it does depend on which side of the table you sit. But, the operating margins I thought were pretty consistent in their direction that suggested CON status did have a significant favorable impact, if you want to call it from a patient's perspective, of keeping margins down. Did I answer your questions, ma'am?
Dr. Clever, we've got a couple more questions, but let me stop just 1 second. We've got a special guest in the room with us today. We'd like to acknowledge Speaker Burns stopping by to see your committee hard at work, Mr. Speaker. We appreciate you being here and appreciate you giving us the opportunity to hold these hearings and look at this complex healthcare issue. Thank you for your support on this. Thank you, sir. Let's see who, Scott Rames had a question for you. What?
Dr. Cleverly, thank you again for the information today. Just a couple of points and a question on the back end. Even with the operating margins that you've shown in the variety of different ways, at the end of the day, I feel like I just want to make a statement here. A wild difference of a 6.90 operating margin to a 4.57 operating margin, just for everyone, that's a percent.
That's a percent, yes.
And I would characterize that as grocery store margins at best. So even wildly successful or incredibly high operating margins based upon what's shown is painfully small in the grand scheme of things. Maybe that's me taking liberties to make a statement, but there's a fine line between an operating margin of around 5% or 4% and 6%. And that's next to nothing. Saying that, as you've done your study and presented this, there was a question around taxation and other questions. At the end of the day, the study's in the aggregate, right? So you're not in a position to talk about, while we know nonprofits, for example, pay no taxes, but from a standpoint of carving charity care out and what's provided by community hospitals, proprietary hospitals, ASCs, and the like, at the end of the day, your study as presented is showing that all in one in the aggregate and not unique and individualized per hospital or healthcare type entity, correct?
Yes, there's no differentiation made in here or breaking out between investor-owned and voluntary hospitals.
Thank you.
Thank you, Mr. Chairman. This charity care jumps off the page. The numbers that you have presented to us, Georgia being the 3rd highest in the nation. And we've always known that Georgians have big hearts. Having a charity clinic in Gainesville, I know that our hospital also participates in that, in the support of that clinic, besides the physicians and dentists from the private offices going into the clinic. Could you at a later date come back and maybe give us some ideas on how to improve these numbers? I think, we've talked about in the past, maybe tax credits or whatever to help move some of those patients back into the office, which would expand the amount of care we can do. Because one of the filters is obviously we have one clinic in Gainesville and 63 dentists. If some of that was going on in the office, it really would expand some charity care. And I know dentists do some charity care. We do in our office, but if there was some help in that regard, that you could expand it. Looks to me like that would be a big issue here, Could you come back at a later date, maybe give us some ideas on that?
Yeah, I'm not certain. And one of the things that would be interesting to take a look at now is what that level of charity care is like, given the availability of 2022 data right now. And that number might have dropped. I would hope that it would have dropped. I don't know the answer to that question.
Right. Okay. All right. I'd look forward to some more support from you on that.
Sure.
Numbers. Thank you.
Uh-huh.
Thank you, Mr. Chairman. And my question is sort of based on what Representative Cooper asked, and that is, do you have a standardized way to talk about earnings, EBITDA, right? Earnings before income tax and depreciation? Because if we can standardize that line, then that may give us a better understanding of how we compare apples to apples. So is there a comparison with EBITDA in your field of study?
Sure. If you're talking about EBITDA to what? To revenue or EBITDA to assets? Typically, we use EBITDA to assets, but is that the number that you're wanting to see?
That's right. And also revenue too, because I think you can do both. I'm on a balance sheet, you can look at one way, but I think on the revenue side, you can look at it on a P&L, you can look at it a different way as well. And so EBITDA both ways is really what I think we're trying to get at, to standardize what we're actually saying.
I understand what you're saying, and we do calculate EBITDA to assets and EBITDA to revenue in some of the metrics that we produce. One of the dilemmas that we have with that, if you break down earnings before interest, taxes, depreciation, and amortization. So, on the nonprofit side, we're really on the investor-owned side too. The data that we pull sometimes from the Medicare cost report, to be brutally honest, sometimes the depreciation number is not as clearly defined as I would like. I think it's included in the cost, so it should be in there, but I can't break out sometimes as finely as I would like the depreciation number. And the same thing holds true with respect to taxes then for some of the investor owns, because most of the investor owns are part of systems, and really a large number of the voluntaries now are part of systems, and you're into a different level of reporting sometimes when you look at some of those. So there are some difficulties that are presented in getting finer gradations in some of that financial data. Your point is well taken, though.
Dr. Cleverly, thank you very much. We were presented your information at our meeting in Albany, but certainly it helps to have you visit with us today and get into a little more depth and explanation of this. And we just want to thank you for taking time to meet with us through Zoom today. And thank you very much.
You are welcome. I wish you the best in your deliberations.
Thank you, sir.
Thank you.
All right. Next on our agenda, we're going to hear from Dave Richard, the Senior Vice President, McGuire Woods Consulting, and this will be online as well.
Mr. Chairman, thank you for inviting me. I hope you can hear me.
Yes, sir, we can.
So let me do some preliminary things, and I'll just get into what happened in North Carolina. I think I was asked to talk about how CON and Medicaid expansion came about, the CMN reforms and Medicaid expansion came about during this past year in North Carolina. So up until March of this year, I was the Medicaid director in North Carolina since 2015. And now, again, work with McGuire Woods Consulting in the Raleigh office. Couple of things that note, I am not a CON expert. After listening to the previous speaker, I feel woefully inadequate to be able to talk about those issues. But in North Carolina, for quite a while, was involved in conversations and ultimately negotiations around how North Carolina would expand Medicaid and what would be the concessions or the compromises that would take place in that process. So from that standpoint, I feel confident that I can at least help the committee understand those items. A couple of things to note about North Carolina is that expansion. We have in North Carolina now a Democrat governor, a Republican legislature. Expansion had been a conversation for quite some time. The Democrat governor, Governor Cooper, it been his top priority for quite some time. In 2022 and 23, and end of 22 and 23, the leader of the Senate and Speaker of the House both came to a place to where they believed that expanding Medicaid would be in the best interest of the citizens of North Carolina, and began a process of negotiating with each other and with the governor to bring that forward. In that negotiation, there were multiple things. I'll just mention them because I think they do tie in a little bit. Is that obviously there were issues around work and work referral program. I think the idea of a mandate was not something that was going to get through the CMS process, but work referral program, using the enhancements that the administration had put out for accepting Medicaid expansion, which for North Carolina resulted in about a $1.6 billion one-time expenditure for the state, or a bonus for the state. Something that we called HASP, which I won't go into detail on it, but frankly, a directed payment process for our hospitals in North Carolina that would allow for an increased rate for hospitals, and they're getting closer to the Medicare payment rates in North Carolina. And then CON reform was always in that conversation. CON reform had been on the agenda in the legislature for quite some time. There were small incremental steps that were made over the years, but not anything significant in terms of that effort. A couple things about North Carolina, we're a rural state like you guys are. We don't have the big Atlanta metro area, but we have several metro areas in the state that are growing in our area. And as they're growing, so are the surrounding counties, if you will, that we have that kind of large city, but smaller counties around that are now getting larger as we go forward. Important in this conversation, and then we, as I suspected, I heard a little bit about you face is that challenges in rural counties around healthcare, and what we've had significant number of hospitals closing in rural communities in North Carolina. So a real concern in the legislature, real concern for the citizens of the state that rural healthcare is now not at the level that it used to be, and trying to figure out how best to address those issues as we go forward. The other thing I'd say is that North Carolina, as if you would have had another chart up there that would have said what are the most CON regulated states in the country, we would have been at top of the list. I think when last I looked at it, we were about third of those 28 states that were doing CON. We were somewhere in the third most regulated effort, meaning that CON was placed on a lot of things over the years that many other states would not have put in place, those CON states that you talked about. So what I described is this negotiation. I would say that as the negotiation began moving, you might imagine that the North Carolina Healthcare Association, the hospitals were deeply involved in that, along with long-term care programs in the state, and to some degree the physicians in the state as well. But mainly the hospitals and some of these long-term care organizations deeply involved in the conversation with the General Assembly and with the governor's office as we were proceeding. As I talked to people in both sides since this passed, what they would all say is that the CON changes have been measured. They weren't they weren't radical in terms of what happened. I think they were measured intentionally to make sure that whatever changes took place, we were able to evaluate as the process went on. I would say that there's certainly members of the General Assembly who would like to see much deeper reforms in that, and there are members of the General Assembly who would like to stay where we are for a while. So there's that tension, which I suspect exists in most CON states. So what happened in North Carolina is once the two leaders of the House and Senate and Governor all agreed that we want an expansion, we went through an extended period of time of sort of public and behind the scenes negotiation about what that looked like. And I won't talk about the other issues, but I'll talk about CON and what ultimately came forward. I mentioned that North Carolina, highly regulated state, one of the places that we all, and I'll say I did, looked around and said, some things just make no sense. We put CON requirements on psychiatric hospitals and chemical dependency hospitals or treatment facilities. And again, not sure what it's like in Georgia, but in North Carolina, getting people to want to build psychiatric hospitals and other substance use service facilities is not the easiest thing to happen. Our Medicaid rates weren't at the highest level of that, and frankly, there wasn't a lot of interest in doing that. So what we realized is that putting any other roadblock, which the CON process can be arduous, made no sense. So that was an easy one for everyone to agree on. It's no longer requiring CON for those facilities. So that in the legislation came out. The other thing that was, I believe, a pretty intense conversation was about long-term care. I mentioned the rural nature of the state for that very reason, is that the fear about removing the CON from long-term care would be that there would be a significant shift in where facilities like nursing homes, and we call them adult care homes, assisted living, and intermediate care facilities for people with IDD. If we took the CON off of that, then there would be a shift from our rural communities to more urban, suburban types of communities where people would go. CON sort of regulates that process. So early on, I think in the conversations that there was I don't know if they would say there was an agreement, but there was a understanding that probably was not the place where we needed to go. Now, there was some changes in that area, which included raising the threshold for if you were going to build something else on the property, which you have a facility, the threshold of that would go up from, I think, 1.5 million to $3 million. That would not require to go through another process for the state. But in the end, there was no removal of CON from those types of facilities. We also, as a state, did not, for years, index anything that we were having CON on. And that was particularly around when you think about replacement equipment for facilities, is that we had then at $2 million, anything above that, you would require a CON. The law changes to 3 million, and it ultimately what it does is it indexes that every year to some medical, can't remember what it is right now, but a medical indexing process, so that we don't have to come back and do this at some other place. There was also the same thing for diagnostic centers, that we raised the threshold for additional requirements to go through the CON process from 1.5 to 3 million for them as well. The big debate, and no surprise to you, I think, was really around ambulatory surgical centers, and the idea that we regulate those, they all requirement under CON process. What could we do in the state to where we reduce the CON regulations on those AmSurg centers? And again, that was I think the stickiest part of the negotiation in this effort. You might imagine there were groups that wanted no changes in that, and then there were groups that obviously wanted to see significant change in the AmSurg effort and exempt them fully from any CON requirements. Ultimately, the compromise for that effort came down to where would the facilities be located, and certainly other criteria that would be in there. So I'm going to read this specifically because I think it's important on this side, is that the facility has to be licensed by our North Carolina Health and Human Services Agency. It has to be a single or multi-specialty AM surgical program. And here I think the two other places where really most important. It's located in a county with a population in excess of 125,000 people. And that conversation goes to the urban rural part of the state. There was a concern that if you had it for some of our smallest counties in the state, then again, what you would wind up doing is causing significant harm to hospitals in an area and other things that would upset the balance, if you would, of healthcare. And then finally, we call them in the new law a qualified urban ambulatory surgical facility. It's required to have 4% of its earnings committed to charity care as well. So I think the two key issues of those was that population threshold and the charity care part of that was debated vigorously. The other thing that the law did, when I talk about measured, is that rather than have everything take place immediately, this provision takes place 2 years effective the date after our department issues the first payment under this directed payment I mentioned to you. So it didn't happen when the law was signed, and you may have known is that all the full provisions of Medicaid expansion didn't take place until we passed a budget just recently in October. But these requirements will not take place until these HASP payments are made to hospitals. What we suspect that is sometime after the first of the year they'll begin. So we're really talking about this change happening sometime in 2025 or early 26 for those things taking place. And then finally, the other issue that was negotiated was for changes impact MRIs. And essentially MRIs were required to have CON inside of North Carolina. The change basically says is that we will no longer have MRIs subject to the CON requirements, but that does not take place until 3 years after these HASP payments begin. So in a broad way of describing what happened in North Carolina is that quite a long time people wanted CON reform. With the work around Medicaid expansion, the opportunity presented itself for reforms to be tied to the negotiations around expansion, which there were multiple other places that tied to that. And then as the legislature began to look at this, and I think again, with a lot of input from providers and other folks across the state and the administration, looked at the sort of tiering how things began to take impact. I think the argument was that if you're gonna remove CON, then people have to have time to prepare to think about what happens to their businesses and how it impacts that, and have folks have the time to raise capital, do everything that's a part of it. But again, I think that was welcomed by the community to make sure that those kind of tiered approach was in place. Mr. Chairman, I could talk a lot, but I don't have any slides for you, so I'll stop and see if we have any questions, and also say that if there are details that you would like and your staff would like me to provide to them, I'm happy to do so. I didn't have a lot of time to prepare, so I wasn't able to do a slide deck for you.
Mr. Richards, thank you very much for being with us today. And we do have a couple of questions. Chair Newton has a question for you.
Thank you again for your presentation. It looks like this was a compromise bill, I guess, and everybody had input into it. It kind of brings up something when you mentioned the urban ambulatory surgical facilities and that 125 cutoff. It's kind of an interesting one. You could have done 115, 110, 100. Could have done it a little higher. We run into a thing we've discussed at times calling two Georgias, to where broadband accessibility, for example, is one way in an urban area and a different way in rural Georgia. Certainly healthcare. And I think we talked about operating margins with razor thin margins in large sections of the state, sometimes dangerously close margins, and then very well run, deep, strong bandwidth, administratively well profitable hospitals in our urban areas. Was that what was going on in North Carolina, that they made that 125? They recognized that urban facilities that are well financed and strong financially can handle some competition to potentially bring down rates, but that the rural areas, it might be the death knell for a lot of our areas outside. Is that what was going on in North Carolina as well?
And so it sounds like you were in the negotiations yourself, but that is exactly what was happening. Is I think, again, this is an opinion, right? Is that in some of our urban centers, I'll mention Wake County, we have in this area 3 large healthcare systems that operate here. And I think, there's in that area, we believe all of them. I think the legislature believe all of them can manage that competition, increased competition. But if you go to some of our smaller counties, and frankly, there are a couple of counties in North Carolina that have around 10,000 people, right? And so if you really take away the controls that CON allows for that, and you add these other things, you could actually really impact that. I think the other part of it is it really began to think about around these urban areas, the suburban growth that we have in those counties. And I heard several people say as well, in this county, what happens if they put it right on the border, right, between one of these counties that has, is really rural, and then right next to an urban area that hasn't quite hit that threshold. So there was a lot of that conversation that went as well, thinking that people might shift to scope at a county border, right, from a from an area. So all I have to say is that you're absolutely correct. That's what this was about. And I don't know how scientific the 125 was. I think it was, based upon where people saw this area, but I think it was, I know it was all based upon let's not do anything that could harm our rural counties any more than people have been in healthcare space.
I like the phase-in factor of it, but I know there's a lot that's gone on with the biggest salary component for hospitals is nurses, which has gone up dramatically to attract and keep nurses. So even if somebody feels like they're in this urban area with a good profit margin, with Medicare cuts and Medicaid cuts and all, it can be dangerous and a risky time. But thank you for your thoughtful presentation.
Thank you, Mr. Chairman. My question is around, it's going to sound strange coming from me, but around supply side economics. Okay, and what I mean by that, I know you're welcome, Republicans. But in the state of Georgia, we have a real problem with maternal maternal mortality in a big way, and so. If we're looking at sort of tax cuts, sort of deregulation and incentives for sort of bringing CON to rural areas, it seems to me like y'all did that in North Carolina as it related to hospitals and long-term care. Did y'all look at like impact to maternal mortality or other places where, look, the demand is here. We have to get docs in these particular areas based on what the sort of the trauma of not having long-term care or immediate care that could present. Did you have anything beyond hospitals, long-term care, where we can look at in Georgia, maternal mortality?
Yes, and I would say that that all of that was part of the calculation, right? Beginning, why our health inequities are so great in some of our rural communities. But I think what I would say is that actually more emphasis was given on certain other areas around that. For instance, we were one of the early adopters when CMS allowed for a state to do postpartum coverage for 12 months rather than 3 months. So, and again, that came from, obviously the administration wanted it, but we had great support across the General Assembly to do that. It also played into a lot of the expansion conversation. I think as our leader of the Senate comes from a very rural county. Our House Speaker in a rural area, and I think that as they saw and recognized the disparities that would happen in their community, saw that expansion was a great opportunity there. And then one of the, I mentioned the signing bonus, we call it in North Carolina, this additional incentive for expansion. Much of that money is going to address issues in rural communities. Loan repayment programs for physicians and other healthcare professionals in an area. Sometimes studies can be really, double-edged sword, but really deep dive into how we can enhance those communities with healthcare professionals beyond just that loan repayment, and several other items around rate structure for workers in those communities and long-term care across the board that were either financed by that signing bonus or allowed for that, because of that, allowed for other resources to be given to those communities. So what I would say is, I think, again, this is a perspective kind of looking back, is that the General Assembly and the administration working together, recognizing these disparities, tried to do it through a lot of different approaches, not just this one around CON.
Do we have any other questions or comments from the committee? So thank you very much, Mr. Richards, for your presentation. We appreciate you being with us today and giving us some good information. Thank you, sir.
Thank you, sir.
Okay, we'll move along on our agenda. We're going to have somebody live and in person with us now. And we're delighted to have our friends come visit with us. We've got Senator Missy Irvin, was first elected to the Senate in 2010, has long and diverse background in healthcare, and we're glad to have her and her colleagues with us today. So, Senator, we'd call on you and ask you to any comments you want to make about yourself, as well as introduce your colleagues that are with us today, please.
On. Okay, there we go. Thank you so much, Representative Parrish. I received your letter of invitation to appear before your committee, and very, very honored to appear here before you and your committee, and to all your colleagues. Welcome from I send greetings from Arkansas. My name is Senator Missy Irvin. I was elected to the Arkansas State Senate in 2010. I grew up in Little Rock, Arkansas, but moved to rural Arkansas, to a town of Mountain View, Arkansas, which is about 2,700 people. Stone County is a population around 10 to 11,000. And we are located in north central Arkansas in the Ozark Mountains area. It's very, very rural, very, very poor. What brought us there at the age of 26 was my husband is a primary care physician, and UAMS at the time approached him to begin a rural residency program. And so we jumped off a cliff together and moved to this tiny little town in north central Arkansas, and raised our 4 children there, and was a private practice, single practice, family practice doctor, and began that rural residency program there in Mountain View, and have practiced there ever since. And so I think in 2010, and that's kind of a little bit of my background. So we were very small business, and practiced in primary care, and I have loved living in this very rural area of Arkansas. And I'll tell you a little bit more about that story. But I'm also the daughter of a retired orthopedic surgeon, but who was also raised in that area of the state of Arkansas as well. So I'll introduce everybody else and continue with my story.
Thanks so much. Hopefully you can hear me. Great. My name is Cindy Gillespie. I'm here because I was the Secretary of Human Services in Arkansas for 7 years. But last year I moved home to Georgia. I'm from here. I was raised in Columbus, born and raised in Columbus, Georgia. And I won't take you through my whole history, but I had the great privilege over the years of working with King and Spalding, and then in the Atlanta Olympics. Moved back here to Atlanta from DC and worked with the Olympic Committee here for a number of years. And after that, moved into, went to Utah with the Salt Lake Games. And then after that to Massachusetts, which is where I started working with health policy. Then after leaving Massachusetts, I went back to my Georgia roots to a firm, McKenna, Long and Aldridge, that is now Denton's US, where I had a practice around health policy and health insurance exchanges, which were kind of a new thing coming along at that time. Mr. Smith, who you'll meet in a moment, joined me in that practice. And eventually the governor of Arkansas asked me if I would come there and come back into state government. And so I went to Arkansas. So now I'm living in Americus, Georgia. So I did not have to fly in. I made the little drive up here. And I can't tell you what an incredible privilege it is to actually be here speaking before the Georgia General Assembly. So thank you very much.
Good morning. I'm Dennis Smith. It's a pleasure to be with everybody this morning. I've spent most of my career in the public sector, working in 4 different states, working for the federal government, both in the executive branch and in Congress. Probably the longest period of time I was ever in the same job was during President Bush 43. I was the Medicaid director for what became Centers for Medicare and Medicaid Services. I held that position for 7 years. I was the lead negotiator for the federal government in developing waivers for states as diverse as Massachusetts, Indiana, Tennessee. I worked with then Congressman Nathan Deal when he was in the House, and we worked on the Deficit Reduction Act together. So that's my Georgia connection. So it's a pleasure to be with you this morning. I do want to emphasize one of the most important things that I learned and lived was every state has to do it its own way. You can't do it in a standardized cookie cutter approach. Every state has its own unique characteristics, its history, its culture, and whatever a state is going to do in this area, it has to reflect that state, nobody else.
And so I think a great jumping off point from there is really just to talk about my story and what motivated me to run for office. Growing up in Little Rock and then moving to rural parts of the state of Arkansas and being immersed in rural life, rural way of life. And in 2010, I just thought, gosh, nobody's really speaking up for these folks. You know, this is rural Arkansas, and rural Arkansas has a wonderful quality of life, just like rural Georgia or rural parts of America. We have a quality of life that people love. They're freedom-loving people. They love their quality of life. They like the rural way of doing things. You know, we're the folk music capital of the world. In Mountain View, Arkansas, we actually race outhouses down Main Street. It's a great place. Come visit. Beautiful place, White River, world record trout fishing and lakes, and it's a gorgeous area. So our number one industry really behind agriculture is tourism, but tourism in my area particularly is very, very important. But healthcare obviously is really, really important. And so if you live, I'm such a believer in rural residency programs, training doctors in rural areas. They understand, hey, this isn't too bad. This is great. Mountain View School District, very, very small. Fabulous public school. One of the top public schools in the state of Arkansas is Mountain View, Arkansas. And so my husband and I was like, well, this is great. Maybe let's try this out. Well, we tried it out and we're still there after 25 years. And so, you know, you look at what are the cornerstones of a rural economy, right? Well, the rural economy is based on healthcare, education, and small businesses. And those small businesses come in all different kinds of forms, you know, grocery stores, gas stations, farmers, cattle farmers, chicken, poultry farmers, whatever. But you've got to support, in my opinion, that rural economic basis and that foundation. And healthcare is part of that rural cornerstone and that foundation. And so when we looked at what was happening across the country with rural hospitals closing and that driving out rural healthcare providers, in Arkansas, I think we came together as a General Assembly representing our folks, our neighbors, the people we see in Walmart, which I literally have an office, I think, sometimes in Walmart. But, you know, we looked at, these are our neighbors. These are the people that go to school with my kids. These are the people I go to church with. And they really do need some assistance and they need some help. They didn't have some of the opportunities that I had, perhaps. But, you know, my husband spent half the time treating you for the flu and the other time trying to get you to understand it was really important for you to take the ACT and apply to college. And I'll help you pay for an ACT. So those are the things that we've kind of experienced in our private practice and running into all these different, very, very important issues that people are dealing with. And so in 2013, you know, we looked at what was happening and obviously at the federal level, and there was a group of legislators that all came together and said, we need to really, really consider this. Those of us who represent rural Arkansas need to really consider how this is going to impact rural healthcare. And I think that's really where the conversation started in Arkansas. So I'm going to jump around in this slide deck, if you don't mind, but I want to start really on number 9, page 9. I'm going to start on page 9 because I want to show you the area that I come from. So if you look up here in the top of the state of Arkansas, where it's Stone County and Searcy County and this whole area of North Central Arkansas, that's me. That's where I live. You can see it's a very, very poor area of the state of Arkansas. It's actually similar to the Delta in the state of Arkansas. Although we have a different makeup of folks there, it's really similar in its economic issues that we're facing here. But we do have very good schools. It's a gorgeous area. but very, very poor. So primarily your medication, your population is Medicaid and Medicare, which are your lowest payers. So very unsustainable for hospitals and healthcare providers unless you're just working nonstop, which my husband has done. So I think that's where we come from. And we really looked at a lot of the issues around rural Arkansans and trying to help them through what they were facing. So these were the numbers that we were really starting with, as far as rural counties having these higher percentage of largely young folks, very, very poor, females as well. If you look at where we live in rural Arkansas, you may be 2 hours from a birthing hospital. If you're an expecting mother and you live down a gravel road for 12, 10, 15, 20 miles, you're literally 2 hours from the nearest birthing hospital for you to go and have your baby. Those are real issues that complicate all of the maternal outcomes and health outcomes that we still as a state in Arkansas struggle with. And so I want to go back and really talk about the journey that occurred in Arkansas. So if you'll go to slide 4, and go back, this is really the 10-year journey that I want to kind of begin with. So in 2014, we began purchasing private insurance through the marketplace under an 1115 Medicaid waiver. The 1115 waiver was very important to us versus a state plan amendment. It was really the opportunity for us to craft what we believe would have been the best solution for Arkansas. And when we looked at where we covered and the amount of people that we were going to be able to put into the risk pool, we looked at the premium assistance program. And so utilizing our partnerships within the state. And so we did this and we started in 2014 and 2016 and created what was called the private option. And to me, this is kind of the financial basis and structure of what we have in Arkansas. And so key points, it stabilized and it strengthened the private individual marketplace, insurance marketplace. And in a future slide, you're going to see that it really did have an effect on lowering premiums or keeping premiums lower for all people in the state of Arkansas. So it really helped keep those premiums stable. It prevented these dramatic and drastic increases in premiums that we were seeing across other states at that time. And so we thought we've got a pretty big chunk of folks, right, that are between the ages of 18 and 64. They're a pretty good risk pool to insert into this dynamic that we have. And if we can insert them in this dynamic, I think it will help stabilize our insurance marketplace and really have an effect on premiums for everybody across the board. And it did. And that's one of the big successes, I think, of our story in Arkansas. Obviously, reducing the number of uninsured was a huge issue. If you don't pay for it, it's not going to be there. You got to have a paying source. And so you had a tremendous amount of uncompensated care that was just being eaten by your rural hospitals and your ERs. And they are on the slimmest of margins. Some, with cash on hand of only 17 days. That is real. But these are the people that work at these hospitals that rely on those jobs. And so making sure that you have uncompensated care was a huge, huge issue that we obviously had in Arkansas. But it's not just uncompensated care at the emergency room. It's uncompensated care at the clinical site and the clinical visits. There's tons of uncompensated care. And my husband was very, very happy to accept a cow in payment. And we've had them. We've had cows in payments and pigs. Great bacon. But, which is great. I had 4 kids and that really helped a lot. But one time we got a horse that cost us more money. But we love this community. It's our passion to serve them. But at the end of the day, we also have bills to pay. We have a small business to operate. We have a light bill. We have employees that we're trying to employ. And these folks, also you have to think about these folks that don't have insurance and that are bringing me a cow, and what they felt like. And so that was hard. I'll be honest, really, really hard. And then we wanted to ensure access to quality healthcare. Just because you're poor and you live in rural Arkansas or rural Georgia doesn't mean that you shouldn't be able to have the best quality of healthcare available to you as you would in a larger city. And I just feel that as who I am as a person, as my faith dictates that to me, I just feel very compassionate about, or very passionate about, I want to make sure you have the same quality of healthcare that I have, and your status and your, and the choices you've made to stay here and be a poultry farmer or cattle farmer shouldn't disqualify you from receiving the best care as, the Waltons. Okay. So I think that was one thing. And one thing here too, I would say, is that we wanted to create a continuum of an existing healthcare structure. And that's why we went with a premium assistance for health insurance benefit. Folks need to understand it's a good thing to have an insurance benefit. It's a good thing to have insurance coverage. And what we found in Arkansas was there's just not a lot of people that were buying a lot of insurance. They just didn't feel like they needed it, right? And then they would just get themselves so, sideways when a catastrophic event happened. Well, you almost have to educate people about, here's the system, here's how you need to take care of yourself. It's financial literacy. And really, it is about financial literacy, but insurance is part of financial literacy. And a lot of people are not trained in that, and don't understand how to navigate through that, even with just financial literacy of mortgages and, all that. But insurance benefit is part of a financial literacy that people really need in education. So we wanted to create a continuum of people getting used to understanding this is the healthcare system. We do have payers. This is how it works. And then not kind of pigeonhole people into kind of a government program, which is Medicaid. And we still have that available. That really should be always the safety net. We wanted to do something different. So then fast forward to 2017, 2021, we had Arkansas Works because we felt that was very important. We want to try to move people. We've got them on the ladder now. We've got them on the ladder. We want to move them up the ladder and off the ladder, right? We want them to understand this is a good benefit to have health insurance. I'm going to look for a job that's going to give me a health benefit. That's very important. And people just don't really understand that or know that. And so at that point, we promoted work, independence, and personal responsibility, obviously, wanting to try to move people up that ladder and then eventually off that ladder. And then in 2022, we created Our Home. And for me, this is where it all came full circle. If you're going to spend this amount of money and you're going to do this and you're going to cover people, you want to make sure it's actually working and doing what it's supposed to be doing. And so health outcomes is very, very important. And I go back to my husband who would write a prescription for go walk 2 miles. And he would get his prescription pad out and go, you need to walk 2 miles every day. And there's your medicine. Because if I can get you to exercise and eat better, you don't have to buy that very expensive diabetic drug. You don't have to buy that high cholesterol drug anymore if you just can exercise. So let's talk about that. Let's figure out who these people really are on the program, and let's cater the policy to them to help really try to give them a healthier, better life. Because ultimately, that's better for your state. It's better for your state budget. It's better for your economy across the board. If you're working to the very height of your level and you're producing your income, you're taking care of folks, you're a great contributor to your economy and to your community, and then ultimately to your state. And so we wanted to really focus, where are these folks? Who are they? We got the claims data from this program, really helped us drill down and figure out who our clients are. What are their needs? And that's when we really decided we've got to focus in infant and maternal, got to focus there. We have really poor maternal and infant outcomes. That is just unacceptable. It's unacceptable to me. We're still in Arkansas not doing well on that, just honest. We've got so much work that we're working and continuing to do. So with Our Home, it was health and opportunities for me. So it's my health, but it's the opportunities for me to improve my life. and to move up that ladder and then off that ladder. And so we created what was called Life 360 homes. And I called Cindy and I said, I just designed it on a napkin on my kitchen island. And we created Life 360 homes. Basically, the idea is saying, we know there's these pockets of folks that just need really a lot of help. Infant immortality, young women. We've got to really figure this one out. Rural health. There's a lot of different issues with folks in rural parts of Georgia, Arkansas, but they are dealing with a lot of issues. Behavioral health. Those were a lot of the issues we were seeing there. And then a success home. So we have a Life 360 maternal home, a Life 360 rural home, and a Life 360 success home. And we saw a lot of veterans on this program. A lot of our veterans were in this program. And so we want them, they have specific different types of needs. Also in this were our at-risk youth. You cannot assume that a child who was taken out of their home and put into foster care and then maybe ended up in DYS's custody and then is released, that they really actually have all the tools they need to be a successful person. They just don't. So we've got to figure that piece out. And so Success Home is really the opportunity to try to focus and zero in on these folks and try to help them and meet them where they are and figure out what their needs are. And so just really in a nutshell, that's really been our 10-year journey in the state of Arkansas. And I will stop talking and let these folks, they're the experts and they have the details of what we did. But for me, I just wanted you to kind of tell you the story behind, what happened in Arkansas. And we've seen really great success. We only had one hospital close, one, and that was it. And so all of our rural hospitals are still there. They are not just being sustained, they are thriving until COVID hit. And then COVID hit, and it's been catastrophic for a lot of folks, but we're still we understand how critical this decision was in 2013. And right now in our state capital, I mean, the talking point is, thank God we did what we did, because had we not, we would have just been decimated in rural Arkansas. We would have had 0 rural hospitals. We would have had 0 rural healthcare, because COVID really put a strain, unbearable, unbelievable strain on everybody in the healthcare world. So had we not done this, I just don't know where we would have been. And with the premium insurance, one of the things that I have to stress is that we're able to pay a higher rate than Medicaid rate. If you look at your state budget, it is really hard to adjust and rise those rates. They need to be raised, but your state budgets probably can't bear that. At least in Arkansas, we weren't. I served as vice chair of Joint Budget Committee as well. I'm chair of Public Health Committee, but understanding your state budget is very, very critical. Obviously, you know that. But being able to partner with our QHPs, we were able to pay a higher rate for services, higher than Medicaid. That had a tremendous effect. And there's more slides that can show you the details of that I'll pitch to them. But that was important because for me, I said, if you're going to just, increase the Medicaid population, we can't do it. We will be the busiest people in healthcare, and we will go broke. You can't do that. You can't overwhelm the system with more people that you're paying at a lower rate. You cannot do that to your rural healthcare system. Just can't. So in Arkansas, we made this decision. I think it's a very good decision. Our state budget is super strong and healthy financially. And so it's really been a success, but I'll let them talk more detail.
Thank you, Senator. We're just going to highlight a few of the slides. We won't go through everything, but as you can tell, she's lived through this whole 10-year journey, which has been a very amazing program in Arkansas to watch and be part of. Just as a quick point of context, premium assistance, the way Arkansas chose to do it, is very different from the way you usually see premium assistance. Usually in Medicaid, what you're going to see is someone is that Medicaid will step in and on a case-by-case basis will subsidize someone's insurance premiums for their employer. And it is very hard to do. Lots of rules, not much take up. Arkansas's idea was, and you've got to remember when this occurred, was there was about to be this new thing called an insurance exchange that was going to offer private individual policies. And if someone was under 65 and making over 138% of federal poverty level, then they could buy insurance there. Well, in Arkansas, this was a state that back then had a 25% uninsured rate. They only covered adults, able-bodied adults with children up to 17% of federal poverty level. So what you had was literally either the highest or the second highest uninsured rate in the country. But when you started looking at that risk pool of people who were going to be buying those insurance products, it wasn't going to be that many, because most of the people who were able-bodied adults without a child or with a child over 17% of federal poverty level, they weren't going to be eligible to buy, right? And they were young, largely female, as she said, and really heavy portion of the rural population. So what Arkansas decided to do, they were looking at all of it. And as she said, they said to themselves, we can't put these folks in Medicaid because the Medicaid rates were so low. And the provider said, we will not treat, we can't do that. So they decided to try an experiment, which was to provide premium subsidies, premium assistance for that whole population, right? Not on a case-by-case basis, but to say, for this whole population, we are going to purchase those for you. Medicaid will purchase those plans, and we're going to buy them through that exchange. And then that way, hopefully, again, most of the people are young, and over time they come off of the program and they get their jobs, their education, they begin moving up, and they can, if they don't go on to employer insurance, stay in the same plan. The subsidy shifts in that early stage of the feds. And then as they go higher up, they're on their own, right? But they're able to maintain their same health insurance along the way. And I can tell you're trying to ask me something, sir.
That question should
Go
be
ahead
asked.
and ask your question.
Okay.
So for the room, again, would you define that population?
Yes.
Who that consists of? I think that would be very helpful.
Sure. No, happy to. That population is between 18 years old and they're up to 64 years old, right? They're able-bodied, meaning they don't need help with an activity of daily living. And so that is who they are. In the case of Arkansas, the way they are set up now, all of those individuals are one way or another are in the private insurance market, all right? And either if they're under 138% of federal poverty level, the state's Medicaid program is paying for their premium. They are subsidizing them. If they're above that, they're in the federal government, as you know, is they're paying subsidy up to a certain levels and it graduates down. And then beyond a certain point, there are no subsidies and you're just buying. But we put them all into, I say we, I was not there at that year. They put them all into one risk pool, right? To create, hopefully, the goal was to create, as she said, a more stable insurance market up there. Reduce uncompensated care by eliminating a lot of those uninsured, being able to stabilize a lot of the providers, grow the health plans around. There were a number of rules. And they did this all very importantly through an 1115 waiver. And they did a waiver for many reasons, but two very important ones. And later, Dennis, I will turn all this over to the technical expert who will go through all this. But the 1115 waiver protected Arkansas in several ways, right? It meant that they had a time-limited demonstration they were doing. It was a 5-year waiver. Obviously, you can withdraw from that waiver at any time, but it was a 5-year waiver. The law they did tied to that. So the law sunset after 5 years. And they've continued to do that so that that sunset means it is looked at as it has continued. So this has gone on now for a decade, and it is just the way things are set up there. This population is all in private insurance. Subsidies are from different sources. I want to take you very quickly through just how it works operationally. It's for Medicaid, which as the Secretary of Human Services, right, Medicaid was under me. Insurance was not. It is different from everything else in that Medicaid is buying an insurance policy. Medicaid is not running. They are not setting the rules. They are not setting the network. They are not setting all those components. The insurance department does, as y'all have that here. The insurance department is the one who works and oversees the plans that are offered on your exchange here. Arkansas is the same way. So each year, what happens is Medicaid says, this is what we're willing to buy. Now, we don't buy everything that's out there, right? For one thing, Medicaid has federal rules around what you have to cover. So, but those essential health benefits are basically the same as what's out there. There's a few wrap things that are not there, non-emergency transportation. So Medicaid covers those separately. But within the actual plan, most everything Medicaid needs is there. Network adequacy is determined by the insurance commissioner, just like normal. You know how all that works. Medicaid doesn't set a rate, right? We're buying this. The rate is set by the insurance plan in their negotiations with the providers. So we're basically paying commercial rates. Medicaid is therefore through this providing commercial rates. As the senator referenced, the way Arkansas did theirs, they have the 90-10 federal match. So those commercial rates are underwritten that way. Okay. And that's provided out through that population. And it is a relationship between the provider, the plan, and now the plan member with Medicaid subsidizing. Each year, it's a very relatively simple process. There's a memorandum of agreement that is done 3 parties, the DHS secretary, the insurance commissioner, and the CEO of the health plan that we're going to be buying plans from. It's about 30 pages. It is not at all like a managed care contract. It's a very simple thing. It just sets the rules. We're going to buy and we'll pay up to this much. We will, in case of Arkansas, we're buying the second lowest cost. So anything that fits that second lowest cost silver tier, and sets out, we'll pay you monthly. You send us over the 834s and we will send back checks. All right. So it's pretty straightforward. Over the years, we've had, you end up with about 200, it ranges obviously from year to year, but you usually have around 280,000-ish people all total in this category. But some of them, as I said, are medically frail, and so they don't go into those plans. They're in a separate Medicaid program. There's another group in there that are the folks who are coming aboard. So just like anything else, Medicaid determines your eligibility. And if you fit in this category, Medicaid says, okay, you're eligible for Medicaid. And yes, you now are going to be put into the private insurance market. Go pick your plan. And people are given 30 days to pick their plan. So while they're picking their plan, Medicaid is covering them under traditional Medicaid. And then once they've selected their plan, they are enrolled by the carrier, just like anyone else would be. If they don't select their plan, Medicaid does auto-enroll them. And we have a round-robin way of doing that, which is what allowed new carriers to come in and for there to be more competition, because there would be people who'd be auto-enrolled with you before you began to before you became well-known. The other component that you see is the plans, of course, pay commissions to brokers and agents for these, right? So there are actual people out there in the market, in addition to navigators who are actually out there working to keep people both re-enrolled as well as get them initially enrolled. There's quite a bit that goes on around all of it. But for me, what was so interesting on this versus our regular Medicaid program is while it's not hands off, it is a very, very different. I will tell you, if you talk to somebody who is in one of these plans paid for by Medicaid, they do not know they are on Medicaid most of the time. They will just tell you that they are on, X and S, that I have the Blue Cross policy, I have the Ambiter policy. They don't think of themselves as Medicaid, and their provider doesn't know either. They show with the same card and it is the same coverage, right? So that's kind of the basics of how it works. Not spending time on these because this is all very straightforward. As she said, if you go to slide 5, you'll see obviously the number of uninsured went down and uncompensated care went down, right? That is not surprising, but it went down everywhere. Very important, the point she made about why one of the main reasons they wanted to do this. The state's budget could not afford to raise Medicaid rates across everything across the whole state. But the state could, using a 90-10 match in that state, they could afford to actually shift this population or put this population in commercial rates well above Medicare in order to really grow the financial foundation in the state on the healthcare side. You see their information on some of the reports about the rates differences. I mean, I know anybody who's in healthcare, it goes, yeah, of course the rates are higher, but it wasn't just hospitals. It was also physicians, 95% higher. But even what we don't show here is specialty, much higher. OBGYN over 200% higher. All right. Some elements like that. And remember, these are our young, healthy lives. These are our women. This was mostly female. So some of those things mattered a lot. She mentioned that the rural hospitals it stabilized the rural hospitals. This map, if you see that empty space right there in the kind of rightish center, that is Arkansas. And so in this 10-year period, we had 57 rural hospitals closed in the surrounding, in these Arkansas and the surrounding states. One was Arkansas, and it was a border hospital. Okay. So it made a big difference in bad debt. I heard you talking earlier today about the margins, as you'll notice, difference in margins, right? Made a big difference. Dennis, I am going to let you take this now because I have, and talk a little bit about what happened to the market.
That this population was about 200,000.
Oh, sorry. But yes. So the population normally is around 280,000, but it ends up that you take about, 50 to 60,000 each month who are either over there in the medically frail. So they're not in these plans, or they're in the churning in, waiting to pick their plan. We end up with about 20,000 new people coming in every month and about 20,000 leaving. It kind of averages out. But so you always end up with it about 200. You'll see our numbers usually show about 225,000.
Would that have been a capacity that you couldn't afford to do this program with?
Oh, goodness, no. Arkansas's Medicaid program. So Arkansas is a small state. It's about 3 million people. Their Medicaid program overall usually has somewhere around 950 to maybe 1 million people. It doesn't get up over 1 million that often, right? And so when you start talking about 225, well, actually almost 300,000 people with the other components right in there, no way they could have afforded to raise rates on everything all over the state in order to be able to get the provider base to support that.
Let me ask you a question before we move along, and there's one other question also. When these folks are determined to be eligible for that program, how long do they stay there, or is there a redetermination that's done annually, or how does that work, please?
Yes, sir. We still have to follow the Medicaid rules in terms of having eligibility redetermined every 12 months. If they're first determined to be eligible, and they could have applied into the federal marketplace, and they send the files to say these people are Medicaid eligible, enroll them. They could have shown up in a county office. They could have applied online. They could have gone through a hospital and been hospitalized, uninsured. Then they become Medicaid eligible. So that initial period of being found eligible, everybody starts in fee-for-service. So you're in regular fee-for-service Medicaid. Then you have a period of time in which you can pick your own plan. And if you do not pick your own plan within a certain amount of time, then we auto-assign them into there. So generally they're getting into a QHP about between the 45th and the 60th day of when they actually start in the QHP. But everybody first starts in fee-for-service.
Thank you. Thank you. And it's a fascinating program in a lot of ways. And I appreciate the recognition that the rates that a hospital or safety net provider or even a private office is dramatically different. And one's not sustainable, as you mentioned, and one that's commercial rates is certainly better to get people into that. Would love to have the 90% match, where I think we're at 67% with our waiver, which is different in some ways. One of the things I noticed is that starting at 20% of the federal poverty level, you have to start paying some cost sharing.
Yes, sir.
Which is a little different than what our Medicaid for 100% and below is. I'm just curious, what happens when people, I think the range you give, somebody maybe paying $85 a year to somebody paying $456 a year. What happens when they decide it's not even worth $40 a month? I think it's an unwise decision financially, but they're young and invincible. And what happens when they don't pay and now they go to a hospital? Or do you let them retroactively? Now they've been in the ER. I'm an ER doctor for a living, but now they're in the ER. Now they got an expensive hospitalization or surgery. Do you get retroactive Medicaid, or is that just the hospital takes that on the chin?
So there is still retroactive eligibility, which is standard 90 days in Medicaid. In the Our Home waiver, that has been pushed down to 30 days. So if you do go into the you go in uninsured, you go into the emergency room, then you are found to be eligible, Medicaid will pick up retroactively that expense in the hospital. So on the co-payments, and again, I think we're somewhat unique, and I think co-payments here under Pathways starts at 50% FPL. We went by incremental 20 percentage points of federal poverty level bands. And the reason for that, again, over time, people become more and more attuned to paying those co-payments. And those relationships, and again, the co-payments are important because we pay the premium to the QHP, we pay an advanced cost sharing reduction payment, which is also had been part of the marketplace, and then we reconcile to actual. The individual, starting this year, that is now a personal liability. Previously, the state was going to back that up and say, well, if the provider didn't get paid, if the QHP paid, but the provider didn't get paid, we'll make that whole. And that turned out not only to be complex, and again, oftentimes, and we collected a premium in which, again, the state then had to go chase the individual and say that's a liability to the state. So we had an appeals process, very, very complicated. We have Arkansas started, and in the new waiver that was renewed, started those co-payments, and they follow federal guidelines. So you can collect, so that individual responsibility can be up to 5% of household income every quarter. So if you go to have a doctor's visit, you fill 2 prescriptions, et cetera, in that quarter, all of that is all of that is tracked by the QHPs. They're responsible for tracking it. And then they put a flag in the system saying Dennis has met his 5% limit. Do not collect any other copayment from him. That has turned out to be well received. Again, you go to the pharmacy, it's a point of sale already. They want to leave with their prescription, so they pay the copayment. I would just say we have not had appeals on this. We have not been in the newspaper on this, which is the biggest indicator. We haven't had calls from legislators on this to say, why are you doing that? People are paying those co-payments. So again, the taxpayer now is no longer responsible for that individual co-payment. So the differences, again, are tiered by federal poverty level bands. So that's why obviously a higher income level could potentially, and again, this is potential, what is the most amount somebody would have to pay? I think that, as I said, by all accounts, it's been smoothly implemented, well received. CMS, actually, we had to tell them how we were going to operationalize this, because again, it's like, well, that's the policy, but how do you actually implement it? As I said, it has gone, I think, pretty smoothly, and the taxpayers are no longer liable for it.
And I just want to say too, I think it's important for people to have skin in the game, right? I mean, you're getting a benefit. You need to have skin in the game. You know, this is a benefit. You need to use it wisely. I mean, but people are, I mean, when I turned 18, I couldn't tell you the first thing about having to go and buy my own health insurance benefit or how to navigate that. And I mean, my dad's a doctor. And so, you know, I just say we have to really understand, you know, the world that some folks live in. But I think it's just really important that you have accountability, and the people that are receiving the benefit need to be accountable for the benefit that they're receiving. They need to have some skin in the game. So that was one of the strong points for us.
I have a question, Representative Cameron.
Thank you, Mr. Chairman. Thank you for your testimony today. Just a two-part question real quick. First, when the people select a plan, are they mainly PPO type plans, or do you have HMOs in Arkansas? And the second part, do you educate the people when they get a health plan so they understand that there's pre-certification and all those different things, so they kind of get an idea? And you laugh. I understand. Go ahead.
I am the queen of prior authorization in Arkansas. I've done a lot of legislation on that, I assure you, but I'll let you.
Yeah, Arkansas does not really have HMOs. And again, it is up to the health plan to educate their member, right? This is very much something where the individual is being treated as if they have private insurance. And so the health plan is the one that is supposed to be educating them. Now, when we talk in a second about the latest iteration, you know, because you build on these things over a decade, what you're going to see is that we're now getting both the plans, the providers, and Medicaid are really getting deeply into now, how do we really work with this population and help them understand what they have to do and help them actually take the next steps. So I would say, you know, if there is a lesson in it, there are some of the folks that you then cover this way are not as good about, I got my packet, I now know who to call, I know what to do, right? So there is a little more hand-holding that is probably needed for a portion of that population.
Thank you.
Dennis, if you want to do the rates.
Got one more question for you over here, Cheryl.
About 10 years in, are there some key learnings or things maybe you would have done differently?
You'll hand it over. We'll just skip right over to that and do that, because I know we're almost out of time. I saw that we're almost at noon. Where did I put the clicker? Here it is. Thank you. We learned most things have gone really, really, really well. All right, as you can see. But like anything else, what happened was when we went for this last round, we all took a deep look at it, both the legislature and the executive branch. We took a deep look at it and said, it's accomplished a lot, but we don't have the health outcomes that we expect to have for a fully insured population that you are paying commercial rates for. That became really the focus of, if we're going to continue this, we are not going to allow that to be our reality. All right. And that is something I will say everybody was aligned around. There is not an issue and was not an issue. So if I could very quickly, the latest version of the waiver that is now operational as of 2022 incorporates a lot of those lessons learned. And it has these goals, which one of the things that we were all very determined, both executive and legislature were determined, would be measurable, and measurable as we went along, not 3 to 4 or 5 years later, we did a study and looked back. All right. We want to know if what we're doing is working or not working as we go. That became a really big part of the way we designed where we were going forward. I'm going to go to the bottom part of this first. Part of doing that was we set, you've got now years of data. You got years of claims. You can look and see what is going on with the health outcomes. So we set a process to actually every year set against the core CMS core metrics to set a level that we expected to see, and a level of improvement then each year will be set, is the concept, right? Over the 5 years, you start with a baseline where they went, Dennis pulled together an incredible team from throughout the state that benchmarked and figured out for each plan against each one of those core metrics, where were they? And then one of the things our law did was it created something new for Arkansas, which I thought was very exciting, which is a joint executive and legislative advisory committee. So that this committee every quarter meets and is reviewing the data, reviewing the progress, hearing from the plans about what they're doing to try to address some of the health outcomes, develop incentives to encourage people both to take care of their health, as well as incentives around economic independence and helping people improve financially, right? So this is an active engagement that goes on. Each year, one of the changes to the agreement now with the health plans is we found out that legally this committee could not actually legally say, these are the new metrics and this must be it. So the committee advises its chair, who is the secretary, as to what the committee thinks next year's health metrics should be, the outcomes expected. And I pity any poor secretary who does not listen, but technically the secretary is the one with the authority then, and that is written into the agreement. And so the qualified health plans agree they must meet those metrics as part of the annual agreement, or there's a financial penalty that will come. All right. But it's a collaborative process. That's the thing. And it is set with the idea that it's going to be reasonable. So like this very first year when they did it, they set as the benchmark for the next year. Among the various plans, there would be within a category, would they just take whatever the highest was that one of them had achieved, with the idea that if it had already happened, then the next year, at least all boats go up to that level in that metric, right? And then the next year there will be a higher one. And so that's kind of how it got set up. And that's the day-to-day oversight. And it is together reviewing it and keeping up with it, which I thought was incredibly important. The big health outcome areas that we chose to address were around maternal and infant health. All right. That is, Arkansas is right down there at the bottom, and that is just completely not acceptable. Rural health, where we focus there, y'all, it's several things, but largely one of the biggest areas of focus you're going to see in a second is behavioral. When we came in with this, Now this population for these years has had behavioral health coverage. And that's great. And they've had it now under, these commercial rates. But, and in the urban areas there's still issues everywhere, but in the urban areas, it's allowed things like crisis stabilization units to come along better, because now many of the people who show up at a CSU are people who are within this population, right? But in the rural areas, you still have a real shortage of crisis centers. You don't have a place. So this new version tackles that with a real focus in the urban areas, as you'll see in a second. And then we just in general, as she mentioned, focused on behavioral health around young people, these at-risk youth. So very fast, because we are way past your time. A third of the babies that are born in Arkansas are born to moms in this program. What we have done is through our home, we have now added home visiting. Our evidence-based home visiting is a little bit different. We're using hospitals as the core, as the anchor for all three of these programs. These hospitals, basically, in most cases, they can use their own employees if they want to, but they usually will contract with someone to go to the home and to work with a mom. A lot of these are rural, right? Work with the mom, both through the pregnancy and for up to 2.5 years after the baby is born. So we have really taken this on with the idea that it's not just try to help the mom through the pregnancy or right there at the beginning after that baby's born, but for many mothers for the next 2.5 years, they need supports, including supports around things like now you have to figure out how you are going to financially take care of this child. So these programs also then work with that mom to help her find good childcare, to help her get into training, to help her get into an education, to help her get into stable housing. So it's a very broad program, and we are excited about it, but we think staying with the mom in the long term is going to help. Rural, we talked about behavioral health. Dennis, if you would you explain, because he does this so much better than I do, how you're doing the behavioral health component in the rural areas?
So it used to be, if you look back 30, 40 years ago, and you compared the urban population to the rural population was actually healthier. They lived longer, they had lower morbidity rates, etc. That reversed. And so now the differential, or what is called the excess death rate, is so much higher now. So in 2004, there were almost 77 excess deaths per 100,000 people in rural counties. That has now nearly doubled. So it is only getting worse, right? So Arkansas, being a rural state, 41% of the population, and actually higher than 50% of those who are enrolled in our home live in a rural county. So we knew we had to put more resources into the rural areas. And as Secretary Gillespie mentioned, selecting hospitals as the anchor for that community. But what we did and CMS is now funded, we had a special provision asking for additional federal funds for startup costs, for administrative costs, but the bulk of these individuals, again, who are either state employees or the hospital has a partnership with another community partner, we are reversing where healthcare is being delivered. Usually you go to the doctor's office, you go to the hospital, we are going to them. And we are going down that gravel road to find people who are not engaged in the healthcare system. So those individuals we call coaches. We have the 90% match rate is available to us for these individuals, because we have determined this is intensive care coordination. So it is a Medicaid service. So we can still get the 90% match rate on it. But then there are startup costs, these other additional costs as well. The maternal, the success, they both screen for social determinants of health. So individuals, as you do go into the ER, you're going to get a screening done in there. And what health-related social needs do you have? There's a big four, right? The ones that show up constantly: food insecurity, home insecurity, transportation, and childcare. So while there's others further down the list, those are the big four. And again, if you are trying to work with someone to help them to engage in a work program or help get their GED, if they are homeless, it's like they don't even hear you. Their immediate need is, where am I going to sleep tonight? How am I going to feed my children? They're not thinking far enough down the road to engage them, right? So you've got to solve those problems first. But we have, so that's been added to the waiver. It's subject to the budget neutrality requirements. I'm sorry, what did I leave out? Yeah, so again, that is the overall, that is one of the most important budget controls in the waiver, is budget neutrality. And while the state is at risk over the 5-year period of time, so CMS at the end of the 5 years, how much did you spend? How many people did you serve? What were your member months? Calculate the per member per month. If you are over that, the state is at risk for every dollar for every individual above budget neutrality. We have never exceeded budget neutrality. We keep the QHPs at risk every single year. So again, we had that. It was a tense discussion with them. And they kept saying, well, budget neutral over 5 years. We're going to apply budget neutrality every year. And so again, the cost of these new Life 360 homes, those get calculated against our budget neutrality cap as well. So that's where some of the important budgetary controls.
I could just make sure that I've highlighted something that I think is going to be very helpful with some of our behavioral health issues in the rural areas. Part of the Life 360 home, if a rural hospital chooses to become part of this, is that the money is provided for them to set up we call them ACU beds here for behavioral health, but they're now being called behavioral health urgent care, behavioral health urgent care beds. And that funding is provided in order to help the hospital actually put in place those beds. It including the staffing that's needed, right? And these often have to be in a secured area, et cetera, et cetera. It is, for most of the hospitals, this is something they are going to work with their local community health center around, but you do need a place for people who are in crisis in a rural area to be able to go besides a jail. And so the hospitals that choose to do this, the funding is provided for that. When someone is in the bed, then that's a medical payment, right? So whatever their payer source is, if they happen to be our home, it will be their plan, right? The commercial rates. If it's regular Medicaid, it's regular Medicaid. If it's Medicare, it's Medicare. When the beds are empty, one of the things we are doing as part of this is paying to have a bed available at all time. And that is being paid for separately as part of this monthly payment that goes to the hospitals. All right. This is our effort to say, all right, we have this population covered for behavioral health. Now, how do we make sure there are supports there at times when, you know, the other centers aren't there, or they don't have to be transported 2 hours away to somewhere else and tie up the local EMS. So
I did want to, oh, I'm sorry, please.
So what happened to when you all when you had Medicaid challenges like we all did, when people were released from Medicaid based on the changes with the pandemic in the post-pandemic period, did those individuals go to our home? Or what has happened with those persons who lost their Medicaid and now you're on the redetermination?
Well, I think it's going to be very interesting to study all the data once it comes in, but I think that Arkansas is going to be better than most states in that your income level, if you were redetermined that you're no longer eligible because Arkansas increased its minimum wage. Arkansas's unemployment rate now is below 3%. So people have earned their way off of Medicaid. So they're no longer eligible for Medicaid. But Arkansas is unique in that individual can stay with their same QHP, their same benefit plan, their same provider network without any change whatsoever. The only change is the federal subsidy is now paying for what our home paid for previously. So there is a continuity there. And again, that's a huge concern. Oftentimes when you switch insurance, you may lose your doctor because I'm no longer in a network doctor. Arkansas is unique in that respect. It's the only state that you would continue your coverage.
Expansion of the number of people who are now going to be in no.
Is a Medicaid program. It's a Medicaid program where Medicaid is buying private insurance.
Right.
Okay.
So if they're
below 138,
they're below
They're still
138%.
below 138%.
Yeah, yeah. And if their income then makes them not eligible for Medicaid, but then and they're above 138% of FPL, then they would go into the federal marketplace. But to his point, it created a continuum so they could keep that same policy in place. It's just they lost their subsidy for it because they didn't qualify for the Medicaid program. But they can keep that same policy and get kind of used to understanding how to utilize it.
because those QHPs selling in the marketplace for the non-Medicaid are the same. They're the same insurance carrier with the same kind of plan.
Dennis, I heard you years and years ago. I think we were in Denver someplace together when you were CMS. You've gone light years ahead of where you were then. I can tell you. I'm trying to get my head wrapped around all this. This sounds incredibly good and sensible. Isn't this more like a 1115 waiver and a 1332 waiver sort of wrapped together? Because we're in marketplaces and Medicaid at the same time?
This waiver is only an 1115 waiver.
I know.
Because we're using, but again, those can be compatible with
Yeah,
what
it
you are
sound-
doing on.
Right. It sounds like a 1332 also, the way this thing is working.
So again, as you are forming as you're taking back the
Yeah.
state exchange and creating that,
Right.
that is how their two waivers can actually intersect.
Yeah. So you're sort of borrowing from that and keeping it on the Medicaid side to make this thing work. Yeah.
Yeah, I want to say back in 2014, when the private option occurred, the original version of the bill only said that it would be a state plan amendment.
Right.
I was one of the deciding votes. And so I took it upon myself to rewrite the bill. And as I was driving from Mountain View to Little Rock to the Capitol, I picked up the phone and I was actually talking to him, and I had never met him before, but I was like, I have to talk to the CMS director under President Bush. He's going to understand and know the differences between why you need a Section 1115 waiver. And I had done enough research to understand this, but not enough, just enough to be dangerous.
Right.
So I actually picked up the phone as I'm driving and I'm writing and making notes on how to amend the bill to make sure that we included that language of a Section 1115 waiver. And I think it was critically important because you as a legislature, or we as a legislature, we have to create accountability for ourselves. And I think that's really critical and important, especially in the Our Home piece. You've got to be accountable to the taxpayers. It's their money. We're just the stewards of it. We're the shepherds of it. And so the policy has to be accountable to see if it's working correctly or not. And to build that in is a good thing, I think, for all of us and for the executive branch and the legislative branch to be in partnership together and to have, I think, that very deep collaboration is really, really important. So, because the executive branch could just create a state plan amendment through rules, well, that's not really where we as a legislature wanted to go. We wanted to have buy-in. We wanted to have say-so. We wanted to make sure there was a strong partnership between the legislative branch and the executive branch on any kind of policy that's going to affect the citizens that I represent. I know them better than you do. I live with them. I go to school with them. I shop at the same place they shop. So we are the policymakers. The legislative branch has a very, very important role here. And for me, that Section 1115 waiver really had that level of accountability that I think a lot of us wanted, plus the budget neutrality, which really was, we're going to hold everybody accountable. We're going to make sure we meet these financial metrics. We're going to make sure that we set good policy, but set those goals and outcomes and measure it. And if we're not succeeding, we got to switch gears. We got to retool, because that's, I think, the democratic process. That's legislation. You know, every time you go into a session, you're retooling to basically figure out how to solve the problems of today, because 5 years ago they were different. And so that's the legislative process. That's a policymaking process. And so for us, this was a way to really hold us all accountable to that. And create that very intricate partnership. And we've seen it, be dramatic in Arkansas. And, we had $0 in reserves. Now we have over $2 billion in reserves for our state budget. And we have a balanced budget, a constitutional requirement. So we've been able to do a lot of things, I think, because we refinanced. And that's really, there are some members, that I work with, my colleagues, all they want to know are the financial aspects of this. For me, I'm the healthcare person. I want to make sure there's robust policy and healthcare policy attached to it. But for some people that you serve with, they only want to know the numbers, because generally it's always about the money. But I can assure you, when you look at economic development, healthcare is economic development. It is a cornerstone of economic development. And if you don't stabilize your healthcare economy, then you're going to spend probably 3 or 4 times as much money over here and trying to rebuild that economy of that little small place. And all of it adds up together to be a very healthy state of affairs, I think.
So thank you very much. Y'all have allowed us to go over time. We truly appreciate it. If there are more questions, or if you just want to send us questions separately, but thank you.
We want to thank you all for coming and be with us. It's a very informative meeting. And I think you can tell from the comments, the questions, and dialogue, there's a lot of interest in what is happening out there and how that can affect all of us. And I think you're so right. When there's no cookie cutter formula to this, every state's different, every person's different in doing that. And I just want to thank you all for being here, and we appreciate it so much. And I'm sure that there may be some questions coming to you a little later, but thank you again for being here with us today.
Thank you. Thank you so much for having us.
We are actually running a little overtime here, but we had 3 people who had signed up that wanted to make a public comment, and we're going to call on you to come and make a very brief comment if you still want to do that. Brian Allen, just identify yourself, please, and we'll be glad to hear your brief comment.
I will not be long. Hello, I'm Brian Allen, Policy Director for the Libertarian Party of Georgia. The last time I spoke before you, I discussed the economic theory of how anti-competitive regulations like certificate of need enable cartelization to serve special interests and harm the general welfare by restricting supply in a way that cannot be accomplished in a free market. Since then, I followed along with you as you've heard testimony confirming that theory empirically. I'm still no expert, but I think everyone can agree that we have a healthcare problem in Georgia. And with all the evidence that's been presented, I hope that you have become convinced that certificate of need is a contributing factor. We need more providers and more innovation to serve the needs of the people of Georgia. When even the local government of Lee County can't manage to get through all the red tape to open an acute care hospital, what chance does the average citizen have? We don't have to guess, because we've heard from people who have tried and failed. We can see all those who have been denied, whether it be for opening a birth center or a clinic or the myriad of other things that certificate of need covers, but we'll never know how many people have been discouraged from even making an attempt. We will never know how many people have needlessly suffered due to the restriction of supply and stifling of innovation that certificate of need causes. Certificate of need has proven to be ineffective at its stated goals of controlling costs and ensuring access to healthcare services. On a more fundamental level, though, the government has no business interfering in people's right to earn an honest living, providing services that people want to purchase voluntarily. The very notion of having some government program to determine whether your services are needed is completely antithetical to free enterprise. That sort of central planning has been tried and has failed with disastrous results. The community determines whether your services are needed through their purchasing decisions on the market. Certificate of need fails both ethically and practically. It has no place in a free society, and we recommend that it be completely eliminated. Other states have done it. Georgia can do it too. At the very least, I hope that you will recommend additional exemptions and reductions in the ability of existing providers to object to a certificate of need. Thank you for your time and attention.
Thank you. Appreciate you being here. Jamie Kavanaugh.
Thank you, Chair Parrish. I just have a few brief comments about some of the things we've heard today. I wanted to start with the presentation from Dr. Cleverly. One thing I'll note is just that states look very different. So in his comparisons, he noted that there are 35 states with certificate of need laws, but several of those states only have certificate of need for one or two things. So it's hard to compare hospital charges, ER charges, when states like Ohio, Indiana, Montana, now South Carolina only have certificate of need for nursing homes and long-term care. So those laws, even though they're included in these 35 certificate of need states, those laws don't affect hospital charges at all. Likewise, when we're looking at colonoscopy costs here in Georgia, Georgia actually has an exception for single specialty ambulatory surgical centers. So endoscopy centers can open here without a certificate of need. That might actually be why the rates are very competitive here in Georgia. There are many of those centers here. They're able to open. So that's also maybe not the best comparison when we're looking at costs for things that are regulated strictly by certificate of need. Also, he mentioned that there are 6 other non-expansion states and compared Georgia's costs with those states. 4 of those states, Florida, South Carolina, North Carolina, and Tennessee, have done very large-scale certificate of need reforms in the past few years. So Georgia would be among their company if it chose to do so as well. And then finally, just to address a question that Representative Beverly had, I know he's not here anymore, but North Carolina doesn't actually regulate birth centers, gynecological services, or obstetric services with certificate of need, but Georgia does. So when we talk about Georgia's very high maternal mortality rates and bad outcomes for mothers and babies, that's something that you really want to keep in mind, that Georgia still restricts birth centers and OBGYN services through certificate of need, while most states do not. Thank you.
Thank you. Last on our list, Natalie Crawford.
Thank you, Chairman. We're going to wait. Give it the time. Thank you very much.
Thank you. We appreciate that. Let me thank the committee for being here today. They've been good about attending all our meetings. Got some great information that was presented to us today. Thank you in the audience for your participation and your interest in what's going on. And we'll continue to work on this problem. It's as we all know, it's complex. If it were simple, we've already have it solved. We've done this a long time ago, but thank you for your input.